Now, normally, this is the point in an introduction when I would ask you to welcome our featured speaker, but today will be different. Due to an unfortunate happenstance, past President George Duff and his family have had firsthand experience with the wonders that are made possible at Harborview Hospital. And so rather than simply introducing Dr. Maier, I have called upon George to tell us his side of the Harborview story. George.
Dr. Maier, we're looking forward to the Harborview story. Thank you.
Thank you. It is indeed an honor to be here. To be able to speak to this type of audience is very formidable. Even though I'm used to large audiences, it's usually about my research or patient care, and it seems to flow much easier than trying to put this talk together. But what I'd like to do, I know some of you and many of you have been touched by Harborview either personally or through family and friends. And I think most of you are well aware of what Harborview is and does. But what I'd like to do is go a little bit beyond that and give you some perspective and some information, hopefully, that you can use in your future interactions, plans, and hopefully help to Harborview, since I'm here always looking out for my home, which Harborview is. I couldn't have done it better. I spent the last 30 years of my life trying to do what Mr. Duff just explained so carefully and so appropriately, and that is to create a trauma care system that allows what you just heard happen. Because that's the kind of regionalized medical care which I'm very proud trauma has been able to accomplish, that allows for the optimal outcome of phenomenally injured patients. And that approach to medicine is catching on in other diseases, but we've been trying to build on that for now 30 years. In fact, as I tell people, I think when I first came to Seattle, it was so long ago, they were inventing dirt the same year. And it's been a long run, but it's been a phenomenal experience for me and something I've really appreciated. As you also heard, I'm a professor at the University of Washington. I'm a teacher. Therefore, there will be a quiz at the end of this, and so I'll give you some high points that hopefully you can take home with you. Harborview started as the Poor Farm down in Georgetown, 1877. If you had consumption, cholera, you were pregnant and poor, you went there for free care, and then you worked on the farm. And so since our very first day, we've been taking care of the same mission population as we do today. It's a bit bigger, more expensive, but it's never changed its mission. And as you know in business, having a clear-cut mission with everybody on board with that mission truly improves the output that that organization can have. We moved up the hill to Madison. The Sisters of Providence provided all the care before they had their own hospital. Later that broke down when they did have their own hospital and the county took over the hospital. But we were the safety net then, and we're the safety net now, as most of you know. But what some people don't know is we last year contributed $180 million plus of free charity care in the state of Washington. That's a lot of money. As a business people, you know, it's hard to hide a $180 million loss every year and keep the business going. But that's basically what the CEO at Harborview is faced with. It's over 1/3 of all the charity care in the entire state. There's 80 hospitals, and one little 350-bed hospital up on the hill does over 1/3 of it. So that's the perspective of where the safety net costs us, and you eventually. It grew like all the other county hospitals, like San Francisco General, Denver General, Charity in New Orleans, Grady in Atlanta. It was a time when all the major cities were growing. They had a population that needed help. They didn't have access to care. The cities took on this challenge as a community commitment, similar to the commitment you folks have to our community, and they created the county hospital system, which frequently dealt with injuries and other problems. So we moved up to where we are now in 1931. A new 150-bed hospital cost almost $3 million. It's about the same as it is today. Then came the 40s. And I think the counties all got together and they realized that at one of their meetings they created the phrase we still use today, and that is, we're not sure we can afford this sailboat anymore. You know, it's like a sump that you can keep putting money into, and there's a never-ending end to it. And so they got out of the business in large parts, and depending on local politics, sort of determined what happened. And many of them went downhill and became very understaffed, undersupported, and were a very big challenge. Seattle was very fortunate because at the same time the state legislature had made the University of Washington Medical School. They had hired the teachers, they had students coming, they didn't have a hospital, and they thought since it was a medical school that they might need a hospital for the people to learn in, so they were looking around, and the only hospital in town that was on the market was from the county to run Harborview. And it became a marriage, which again, many people still don't know. Since the mid-40s, Harborview is basically managed, run, everything at Harborview is University of Washington. I'm a professor at the University of Washington. Every person who works at Harborview works for the University of Washington. It's a major teaching hospital for the University of Washington. You don't maybe recognize it, but if you're unfortunate enough, you can have the same resident take care of you if you go separate months to Harborview, the University, Roosevelt Clinic, Seattle Cancer Care, or even visit a friend at the VA, and the same resident will be standing there as they rotate through these hospitals. It is one family. We are all equal and the same. We just have different interests and focus in our careers. It's now run by the university still, but it's owned by Harborview, by the county. The county contributes no money. The county owns the property, and when it comes to passing bonds to build new capital projects, it's very nice to have the county as a backer and allows us to do that. And it's worked very well, and the citizens of the county have been very supportive of Harborview for many, many years. But our board of trustees are political appointments by the county council. We're run by state law. And if you, again, being in business, you want to try and make an organization unflexible. That's the kind of structure you want to have. It used to be for every $100 purchase, it had to be debated and okayed by the county council. So you can imagine when something happens and you want to respond quickly, some of the challenges that the hospitals had moving forward. And it's still that way, but it's becoming much more flexible and able to respond. So it became a major trauma center. The population grew. One of the major events, again, in trauma is wars, unfortunately. Vietnam and Korea told us that fast response, as you heard, being at the scene, delivering the patient to definitive care is the way to improve outcome. And the Seattle grant to the fire department, along with Miami, created the first out-of-hospital response system in the country. And Seattle was the only one that added trauma on the cardiac response. And ever since then, you know, it's grown up with the medic system and it's become a leader. We now have over 6,000 trauma admissions alone. It's in the top 5 in the country, and it has worked very well. One of the things that's been very fortunate in Seattle also is in a lot of cities, if you have trauma at every major hospital, when you try and regionalize it and direct everything for resource consumption, for efficiency of care, for value, it becomes a very big political challenge because nobody likes giving up things. In Seattle, it's always been at Harborview, so it's allowed us to develop a system that's optimally, I think, effective in this country right now, because we have had that working relationship, a very good working relationship throughout the county. I might mention number 5, within the top 5 in volume, a recent study by the University Healthcare Consortium, which has about 100 academic centers, did a severity-adjusted mortality, and Harborview is number 1. So we do good work, and we're very proud of that. That doesn't mean we can't be better, and there's a big effort right now, as most of the country in medicine is doing right now, is to become patient-focused. We're spending lots of energy and effort to treat patients like true clients and their families and try and make the experience the best it can be under the circumstances. The other thing that's great about Harborview for me is I have never had to ask anyone if they have insurance. And as a physician and my personality, that's been one of the biggest blessings I've ever had. It's an amazing place. And the whole Harborview institution, as I said, has a mission, and people who work there know why they work there. They can make twice as much going 4 blocks down the street. But the reason they work there is because they believe in the mission and they appreciate the work that we're doing. And it's created a family atmosphere that, again, is very hard to replicate in medicine. We all pitch in. Everybody works hard. We all give up things so that other people can get their work done. And it is, if you've ever been there and seen how the nurses work and their commitment, the support staff, it is a phenomenal experience from the amount of commitment that the people there have for patients. So we've right now grown. The two last things I'd like to touch on before I open this up to questions, because hopefully you'll have lots of questions so I can answer things that you want to know rather than just give you what I think you should know. We do a lot as part of this spectrum in prevention. The Harborview Injury Prevention Center has been there for 15 years. It was initially funded by the CDC. It's the home of the bicycle helmet campaign that has now been adopted throughout the world. We took helmet usage from 30% to 90+% in this town. It has cut head injuries in children 87% from bicycle crashes. I mean, these are things that go on every day that people just don't know, and it's been adopted throughout the world as a major template to use in implementing bicycle helmets. Seat belts. We've done a lot of work with alcohol and recidivism, implementation of intervention to prevent people from coming back over and over again. It's cut recidivism in half over what it was. And lastly, just to touch on another component that many people don't know, is we do a lot of research at Harborview. We're part of the university. We're all professors. We are all expected to have a research and academic component to our careers. And you may or may not know, $40 to $50 million of your tax money goes through Harborview every year just in research support. It's a very active process there. We have many things going on. My own laboratory, I'm looking at the genomics of injury over time, working with Stanford and Harvard. It goes all the way through preventing organ failure, and we also are a major contributor to global health. It started with AIDS because that's our mission population, and now we are developing a major global efforts in Africa and throughout the world trying to impact mortality. So again, it's a mature system. We've had luck. We've had good working neighbors and other medicine institutions in this town, and I think we've come up with a very good product. So I just end with saying, what can I do for you? Please, questions.
Okay, there is time for questions and answers. So again, get the attention of somebody with a floor mic, and we'll go back and forth between people with floor mics. There's a question back there. Oh, here we go.
That's a broad question. The question was, is when the 9.0 an earthquake hits, what should you do? And probably be on vacation, number one. But in regards, you know, our last major bond issue, a major component of that money went to stabilizing the North Tower that we've had since 1975. And it was very effective. They say that, I don't know if it'll go to a 9, but if it hits 8, we're covered. And the new buildings that just went up are covered. One of the other things that's little known is it's a problem which we're trying to correct. We're going to build our own steam generator because we run off of steam from the bottom of the hill for heat and for sterilizing and so forth. And so one of the things we worry about is losing our steam pipes coming up James. And so we're going to build our own plant. But it's becoming self-contained. We have many contingency plans. We go through the practices, whether it's bioterrorism or an earthquake. All the hospitals communicate twice daily at least. We have those communication channels open and working so that we know they will happen when we need them in an emergency. And as each hospital is injured or not damaged, we'll be able to shift patients and shift the flow of patients to the hospitals that have the capacity to take care of them. And so a lot of it is that planning and organization. Again, if this convention center falls on I-5, that's a big problem for transport for anywhere. But again, all the contingency plans that we can make, we have been trying to make. And the integration of the fire department and the hospitals in this county, the people who live here don't know. You know, they say Northwest nice. This is one of the big pluses of that. The community really does work well together here, which you rarely find in other major cities. So it's well organized.
I understand that the Harborview is a regional trauma center. I'm a fire commissioner up in Snohomish County. I know that we bring a lot about trauma patients down here, and our medics also trained by you. So have you been, you said there's any contribution from other counties around the region to your finances?
If it is, they haven't told me. To my knowledge, the way Harborview works is since it's run by the University of Washington because of state rules of where money gets passed and so forth, and as I mentioned, the county wanted out of the business, the county got out of the business. And unlike what many people think, the county doesn't slip us a few million every year just to keep things going. There's nothing other than underwriting the debt on the bonds and the building depreciation, which is a big, I'm not belittling that, that's a major contribution. But we have to sustain ourselves just like Swedish, VM, any hospital in town, and we have to charge patients, and we have to try and get as much money as we can out of insurance and the CMS government to support our activities. The thing that keeps, and you say, well, that doesn't match with $180 million a year you're giving away, and it doesn't. And what keeps Harborview going currently is disproportionate share. And it's prorated on how much charity care you give so that the Department of Health has the option through Medicaid pass-through monies to basically give us lump sums of increased reimbursement for Medicaid, Medicare patients that the other hospitals don't get that don't have as much charity care. And it's basically that money that keeps Harborview open and makes up the deficit. The problem with I don't want to get into politics, but with the new health care reform, one of the line items in there is, since everybody's insured now, we don't need disproportionate share anymore. And if they and the plan is to totally take away disproportionate share from the states, from Medicare and Medicaid pass-through. If that happens, Harborview should last about 3 days. And so that's a major issue. And as safety net hospitals, and we're not the only one, to me, somehow they have to become a line item on the government's budget, because if they eliminate disproportionate share, which has worked very well, we can't financially stay alive. But other than that, we work just like any other hospital, billing and trying to recoup as much as we can. That's why I'm here, because for every one of you that go to Harborview with insurance, we bill a lot of money.
Before I hand the mic over to Todd, I'd just like to thank you for taking care of my grandson, who was in a serious skateboarding accident up in Bellingham. Thank you.
Thank you.
How well do hospitals and medical boards coordinate regionally and nationally to create highly specialized trauma types centers like Harborview's burn unit?
Unfortunately, it's total anarchy. And again, we in Seattle, as I mentioned, are phenomenally lucky because we grew up as the only trauma center, so therefore we didn't have to, quote, fight to take it away from someone else who wanted it. In fact, my friends at Swedish or VM or wherever, the CEO comes up with a good idea, hey, we should be a trauma center, it's good for publicity, and then they go talk to the surgeons and they say, you want to do what? You want me to be here between 2 and 4 a.m. every night taking care of injured patients? That's not going to happen. And so we have a lot of support from the community to keep doing exactly what we do. But elsewhere, it's very difficult. In fact, I've had a great privilege of being on a NQF, which is National Quality Forum, which is a public-private juncture that's been given the charge of setting up measures of quality care nationally. And we just had a meeting where we're trying to set up a structure for improving and creating measurements of quality care for emergency medical services throughout the country. And that's the reason why it's there, is because it really is disjointed in most major cities. And so this is an attempt through funding leverage to make people play in the same sandbox together to truly regionalize. Like I said, trauma has led the field for 30 years in regionalization, and we've done it to ourselves, which I'm very proud of. We're doing the same thing now with stroke, with acute cardiac disease, and it's been shown it saves lives. Plus, it costs less money because it's resource optimized. And so you will see more and more of that, and organizations such as the NQF is going to be trying to get the measures placed on reimbursement to drive that regionalization development.
Thank you for taking care of my 7-year-old niece who had an aneurysm last year. My question for you is, you expressed that during times of war, we get most of our trauma advancement around medicine because we have a lot of opportunities. Aside from sharing interns with the VA, what other partnerships do you have with the military that advances your work?
As you just said, it's a member equal sister of the community, of our academic community. It's a major training place, and we accept rarely soldiers that come back from Afghanistan and Iraq. The military, since Desert Storm, has had a phenomenal improvement in their care delivery. It actually is a very good care delivery model right now, and they actually streamline the care into rehab and recovery to Walter Reed or San Antonio, few to Madigan and other places, and it's worked phenomenally well. I, again, had the honor, I was in Afghanistan in October working as a invited guest to CENTCOM to actually do a survey of medical care in Afghanistan. So I got to travel around and talk with the PJs and the paramedics and the Black Hawk medics and so forth, and the care is phenomenal. It is excellent care compared to what they were doing. And they have these critical care flying transport planes that they get the guys out of Afghanistan within 48 hours back to launch school, where I've also had the opportunity to work, and then back to the States. And the system is really good right now. Now, the bickering between the different services and stuff, and that's still a military problem. But the actual care that the injured guys get is superb. If I could ask you all, though, do one little political thing. I shouldn't do this, but I will. The only thing that was phenomenally discouraging about Afghanistan was the number of double and triple amputees that war is creating right now. The first day I was there, I went to the ICU, and there were 3 young guys, 2 with both legs gone and 1 with both legs and his left arm gone. And the guy looked just like my son, who's 22 years old. And that war is creating a population of multiple amputees that the world has never seen. And they're 20 years old, they're going to live 50 years. And as you say, the VA and I think us as a society owe those people a whole lot. And it's going to be a phenomenal challenge. So if any of you can sort of shift things, like I cornered Norm Dix on the airplane about 3 weeks ago, and I didn't realize I had such a major impact on his approach to the war, but I've taken credit for the whole thing. But I agree with him. It's time to come home. It's really, these young guys, it's devastating to take care of them. And their attitude is so phenomenal. It is such an honor to take care of those young guys. It's amazing, but it's a big load.
Question down here.
Our family is very appreciative of your role as a teaching hospital. Our son-in-law is in UW Medicine, and he's done a psych rotation there, which was interesting, apparently. But he's been going through this process of figuring out his specialty, and I've been very interested in learning that there's sort of a decline in those going into family medicine, apparently, and a lot of doctor friends talking about that, and I'm just curious as to what's going on and what role this hospital plays in that whole arena.
Well, I can't take credit for Harborview. The University of Washington is #1 in the country in percentage of their class that goes into family practice every year, and they're very proud of that, and it's part of the WWAMI connection through the Northwest states. And it's a phenomenal tension because most places that have high-level academic research institutions don't train family practitioners. They train, left-ear neurosurgeons. But the university has been able to balance that tension phenomenally well, and as I say, have the largest percentage of family practitioners, while they still have we're number 2 in the country in NIH funding for the research at such high quality. So there's this very strong commitment to that. But to answer your question, people in general aren't going into general practices. They're going into specialties, and there's lots of reasons for that. I could be snide about some of them, but people are just attracted to becoming superstars and super specialized, and it's just a human nature thing that attracts more people than attracts people who want to go into family practice. Reimbursement's part of it. Family practice is grossly under supported for the amount of work they do. And so there need to be adjustments, there need to be reasons for people to go into it. We need to give them reasons to. So we're trying, but it's just been a trend. In fact, in general surgery, one of the big problems, which you folks probably haven't run into yet, but unfortunately you may be running into, is access to care. You can't find physicians at night for emergencies or whatever. They're all going away. People who do breast cancer don't take trauma call anymore. And the number of people willing to do what I do is decreased, just like family practitioners. And it's putting a real stress on all of us to provide care to people that come in that need it as an emergency. And so there's actually a new specialty called acute care surgery, which I helped create. Whoops, thank you. To deal with just this, and it's create a bunch of general surgeons who not only do trauma, but they do your gallbladder if it acts up in the middle of the night, your appendix, you rupture your colon. And so we're creating a cadre of these people to go out. And fortunately, the hospitals, to provide service to their patients, need to provide this service so they're willing to pay for it. So now there's a financial reason to do it, and actually the field is growing rapidly. But access to care for Americans is going to be a challenge over the next 10 years, unfortunately, until we figure out how to deal with it.
Great. Thank you very much, Dr. Maier. Thank you so much. I wish there was time for more.
Seattle Rotary Online is made possible in part by a grant from First Choice Health, working with the Washington Health Information Collaborative to use technology to bring better health care to patients throughout the Pacific Northwest. First Choice Health.